Hi everyone. Sorry about the slight delay in starting, and we're getting better at using Zoom. It looks like we've got it working this time, so that's handy. Okay, so I'd like to begin by acknowledging the traditional custodians of the land from which we host today's seminar, the Wurundjeri people of the Kulin Nation, and recognise their enduring connection to these lands and pay our respects to their elders, past, present and emerging, and to all Aboriginal and Torres Strait Islander peoples who join us today. So, thank you for joining us on World Parkinson's Day today for this special seminar, this WeHi Parkinson's Disease Research Centre seminar. World Parkinson's Day is an important time to recognise and celebrate the resilience of those living with Parkinson's, including the more than 200,000 Australians and their families and carers. And it's great to see some of our consumers here today who have made fantastic contributions to our research program. So I wanted to just highlight a couple of quick housekeeping items. I know we're running a little bit behind. I want to highlight Walk in the Park, which has been organised by Parkinson's, which will be held on the 21st of April. If you could join, that would be fantastic. Or if you could donate to our WeHi team, if you have the means, we'd love your support. And I just wanted to highlight, because it is World Parkinson's Day and this article just got published just a couple of days ago, that the GLP-1 agonist clinical trial results for Parkinson's disease came out for a drug called lixisenatide. And it showed in this trial a small but promising improvement in Parkinson's patients. And given that lixisenatide is considered to be an old generation GLP agonist, the newer one, exenatide, which also entered phase 3 clinical trials for Parkinson's disease, that has been completed and the results are in, and we eagerly await to see whether that's giving positive outcomes. So there's this interesting link between metabolism and Parkinson's, and hopefully there's more positive outcomes from that. So today it's a pleasure to introduce today's speaker, Professor Dominic Thyagharajan, who I think is an ideal speaker for this important day. Dominic is a neurologist specialising in movement disorders and is head of the Deep Brain Stimulation Service at the Alfred Hospital and is adjunct professor of neuroscience at Monash University. He did his clinical training in St. Vincent's and Alfred before heading to the US, working at the Mayo Clinic at the Columbia Presbyterian Medical Center in New York as an NHMRC fellow. Upon his return, Dominic established a deep brain stimulation service. Dominic has also published broadly on movement disorders, including some of the early studies on mitochondrial dysfunction in Parkinson's. So please join me in welcoming Dominic. And Dominic, very interested to hear about your latest work.
Thank you very much for the introduction, Michael. I was asked by Michael and others who invited me to talk about some research, but also a little bit about deep brain stimulation. So I've tried to do both in one talk, so maybe not as well as I could if I was talking about something more focused, but I understand it's a rather broad audience. I should disclose that I mentioned later on a device by its trade name, and I have, which is disclosure relevant to this, conducted workshops for that company for their Southeast Asian division in Korea mostly, and I've been paid for that. It's, that dopaminergic cell loss in the nigra occurs in Parkinson's disease is not really new. There are two threads to this idea. One is neurochemistry, dopaminergic cells, and the second is of neurodegeneration, loss of cells. But we know this. Tretyakov in 1919, suggested that a body found an inclusion body in the midbrain described by Louis should bear his name, and that was the hallmark of the disease. So we know that from pathology going well back. And the second thread is of neurochemistry, dopamine. And Arvid Carlson got the Nobel Prize for this, and people thought he's credited really with the discovery of dopamine in the brain. But actually, Catherine Montague, some months before, had showed that dopamine existed in the human brain by paper chromatography in 1957. And if you look up Wikipedia, we know all about David Carlson's children's names, but not much about Catherine Montague. The loss of the melanin-containing pigment where these cells are disappearing in Parkinson's disease is kind of what we see on the gross level. And this was seen by Brissot in the late 1900s. And I'll credit this slide to a colleague of mine at Flinders University, Dr. Wei Ping Gai, who gave me this lovely picture of this eosinophilic inclusion in a midbrain dopaminergic neuron with this halo around it, the Lewy body. Whether it's, it's at least a very, very strong marker of the disease, whether it's part of the pathophysiology or not, the controversy rages. And it's not just the upper midbrain that we see this, but this kind of pathology, intraneuronal inclusions and deposition of alpha-synuclein containing misfolded protein up and down the brainstem, and then eventually up into the cortex, starting very low down in the lower brainstem. And you can see this, not just the brainstem, but the olfactory apparatus. And so this has led to this wonderful idea, which I'm not really going to talk about, the so-called Bragg hypothesis, where there's this kind of spreading pathology from low down, maybe even the gut, because we see this outside the brain even, and perhaps some kind of transsynaptic spread of misfolded protein, like a prion. That's a kind of the sort of sexy kind of idea. Because why is it sexy? Well, it leads to some point of control where one might interfere with the spread of a misfolded protein. Anyway, in the midbrain, of course, this lower brainstem pathology leads to all kinds of manifestations. It's a very complicated disease. But what we recognize as neurologists is when the patient presents with these motor features. And the cardinal features are, of shaking, stiffness in the muscles and slowed movement, and a gait disturbance. And that's a picture or drawing by Richard Gow's, very old picture. It's still used extensively in teaching, showing that, the motor manifestations lead to characteristic deformities of posture. That's shown in his wonderful line drawing there. One thing I do want to start talking about now is disability, because these cardinal motor features, they're often quite obvious, maybe not rigidity so much or slowness always, unless you look carefully, but tremor is very obvious sometimes. But that's not necessarily the cause of disability. I'll show you a video in a minute of a person who's he's on an operating table. We're just about to do a deep brain stimulation procedure on him. And when I run the video, I'd like you to notice a couple of things. That he's got prominent tremor. It looks, very dramatic and so on. But actually, when he goes to speak, the tremor suppressed. And when I ask him to move, the tremor suppressed. And even though it looks very obvious, to this man, the tremor actually isn't his major trouble. Can you open your mouth for me? Pop your tongue out. Can you hold your hand out, Frank, like this? And then open and close your hand like this for me now. So the tremor largely goes away when he's moving. And of course, we can eliminate that tremor with with what we're about to subsequently do. But as I said, the focus in the early part of the last century and the late part of the last century was on the midbrain. But we now know that there's a lot of non-dopaminergic cell systems which are degenerating in Parkinson's disease. In fact, it was known very early on that the locus coeruleus was involved. nuclei in the brainstem involved in gait and posture, the particular pontine nuclei, midbrain nuclei important for sleep, the raphe nuclei. And then I already mentioned the lower brainstem nuclei. And this kind of, you can make some kind of rough correlation between this and very early symptoms such as loss of smell or constipation or other early features of the disease long before the motor manifestations become evident. Disturbances of sleep, of mood, of emotion, of balance, and of freezing. And I'll talk about that in a minute. This leads to a different, mainly the main subject of my talk, which is that there's more to the motor system in Parkinson's disease. And what so much of the focus is on the motor system, but it's these non-motor aspects of the disease that really cause a lot of disability in Parkinson's disease, for which we don't have any treatments, good treatments. And the sensory system is very, very important. If you look at the literature, I mean, there was a famous paper by a great neurologist, David Marsden, perhaps in the last mid-century, which was entitled The Mysterious Function of the Basal Ganglia, and he skips over the sensory system in one line in the introduction. But it wasn't not there. And, you know, if you go back and look at a paper in Brain by Gordon Holmes, 20 years before that, it was an 80-page paper, and he starts off by saying he craves the reader's indulgence. And it talks about the sensory system for 80 pages. So any paper that starts with craving the reader's indulgence, I think we have to go through it very carefully. But the hearing, the auditory system is involved, perception, visual perception. We know that patients can't tell red and green very well. I encountered this in the lab first when we were using some testing involving moving colored gratings, and we stupidly chose red and green colored gratings, and we found the Parkinson patients couldn't see it. And yet they never complained about that. Tactile perception, proprioception, which is the sense of where your body is in space, and a very important sense, which is that of inner timekeeping, temporal perception. So we think of senses as being 5. I mean, that's, but obviously there are many, many more senses than that, and some of them don't really have names, I don't think. And it's the interaction of all of these senses, the integration of this with the motor system, that leads to such perceptions for which we don't have good names, like a sense of self, of where your body, of the ownership of your body. And a sense that you can move. If I could use a word for that, I would use the word, but I can only describe these things. I suppose on a personal anecdote about this was that it did really, I still remember that to this day. A patient many, many years ago had returned to our center. I was working in South Australia then, having had a deep brain stimulation operation, which was very successful in Sydney. And the neurologists and neurosurgeons there were very happy with the surgery. The patient seemed, by all accounts, to have done very well. He was moving very well and so on. But he said that he couldn't move. And it was obvious that something was missing, his perception that he could move, because he would move. He would walk around, he'd drink his cup of tea, and he'd say, I can't move. And it was causing enormous distress because he felt trapped in his body. And we thought maybe this is something that we simple country neurologists can't understand. We should ask the psychiatrist. The psychiatrist came and felt that there was no psychiatric problem whatsoever. This person wasn't depressed or, altered in some sort of altered reality or hallucinating or anything like that. So we were at loss of what to do, and we said, well, we can't keep you in the hospital forever. You seem to be able to move. You should go home and go home tomorrow. And the poor man, I mean, he was found having killed himself in the ward that very day, which was a terrible, terrible event. Must have distressed him enormously, apart from the fact that he felt that he couldn't move, but did move to the point where he could commit suicide, he must have felt an enormous sense of overwhelming distress. That little anecdote has never really left me. Freezing of gait is often, talked about as a kind of a motor problem, but I've got a brief video here, and you can see that this is more complex than just walking around and not walking around. This person is using sensorimotor cues, and the environment is crowding in on him to produce this terrible symptom. It went on for 15 minutes. I haven't done the whole video, it's edited heavily, but he's trying to walk and get started.
Take your time, I don't want to cause you anxiety.
Now, doorways and so on are visual cues that seem to trigger this tendency to get stuck. And then he actually uses his own body with little tricks like that to generate some kind of sensory motor cues back to his brain to activate an alternate program so he can actually run. You learn a lot from patients about the brain. So my current PhD student has just done recently a review of what sort of brain networks are involved in sensory perception in the brain. And the slides here, I've used all these sensory modalities like proprioception, tactile perception, temporal perception, visual perception, auditory perception, etc. And she's mapped out, I think, in something like 108 studies in humans and animals. And here she's focusing on the human studies, which areas of the brain are activated, which each of these modalities in normals, which is in green. And in the areas that are also got a red highlight around them, is areas that are abnormal in Parkinson's disease. And in each and every case, the red areas in each of these sensory modalities involves these deep structures in the brain, which are the basal ganglia. And here, in this case, the globus pallidus and the caudate, here the caudate in the case of proprioception, and so on and so forth. So if you were an engineer designing the brain, well, you'd put the control center and the integrating center right in the middle, which is kind of where it is. And we know that the structures that we target in deep brain stimulation operations have wide connection with all parts of the brain. The so-called association cortex, which integrates various inputs to the brain, vision, touch, etc. Emotion, the amygdala, and the motor system. So this is central integration. So I wanted to kind of test this a little bit in patients with Parkinson's disease, because that's where the pathology is occurring by the time they come to see you. And so I thought that we'd investigate this interesting illusion, which is an illusion in which various sensory modalities are integrated. It's called the rubber hand illusion. Maybe some of you have heard of it, but I'll show a video of it, which will describe what it is that I'm talking about. And Catherine Ding, who was my PhD student, did all this work. So we wanted to know whether this was actually altered in Parkinson's disease. So what is this illusion? So I've just downloaded this video and edited it from the University of Amsterdam. It shows you the illusion if you're not familiar with it, and there's lots of YouTube videos you can go and see if you're interested in it.
The illusion works as follows. A person's real hand is hidden from view and visually replaced with a fake rubber hand. By brushing both the real and the fake hand simultaneously, the brain merges together the feeling of our own hand being touched and the visual input of the fake hand being touched. The more activation of the brain areas that integrate the visual and the tactile information, the stronger the feeling that the rubber hand is part of our own body.
Like, I actually feel like that's my actual hand, and my hand's just really pink for some reason. It's swollen. Why is it? This is so weird. Like, I'm looking down at it, and
only a matter of minutes, this can lead us to fully adopt the rubber hand as a part of our own body.
Yeah, the more you do it, the weirder it gets.
When this new hand is threatened, we respond to it in the same way we would respond if it was truly part of our own body.
Yeah, that gave me a fright.
Whoa. Whoa, that's so odd. Oh my god. Nah, I don't like that.
So that's rubber hand illusion. So Catherine published these findings in Parkinson's disease, and she did this research where she set up this device here. She built this herself. I mean, it cost $70. She went to Bunnings and got some timber and glass. There's a left compartment. This is a little bit more complicated. We had some targets where we're doing reaching tasks as well, and a 3D tracker here, and a rubber hand that you got from the magic shop for $5, a couple of paintbrushes, and the compartment, which was the hidden hand of the person. In that little video that I talked about, it was a bit crude. It showed you a picture of the brain. It said there's integration of vision and the sense of touch. But the rubber hand illusion is more complicated than that. In addition, there's an integration of temporal perception, because you have to stroke the hand repeatedly and at a certain with a certain type of pattern. So a synchronous pattern, which is where we stroke the hands together, readily generates this illusion. But asynchronous, where you stroke one hand and then the other, doesn't produce the illusion as strongly. So there's temporal perception, which is integrated. There's some internal timekeeping function of the brain that it'll be very fascinating to understand. More to it, there's something called proprioceptive drift. In other words, if you do this rubber hand stimulus, then the person doesn't really know where their actual hand is in space. They make an error. If you have a marker here, this is a tape measure, and you ask them where they think their hand is, and then you measure the error according to where it really is, that error is increased, and that's called proprioceptive drift after you start eliciting the illusion. And to do this experiment, I was very pleased to work with a couple of colleagues at Monash University. Jakob, how he's supposed to be a philosopher, but actually I think he's more of a neuroscientist than a philosopher. And now Suchiya at Monash. But the reason Jakob is that he was very interested in this illusion and the sense of self. So firstly, we had the person make a baseline estimate of the position of their middle finger. There's the person, and there's the tester, and there's the rubber hand, and there's the other hand, of course, the hidden hand. And then we do stroking, as I said, in either this asynchronous or the synchronous condition. And then after a couple of minutes of stroking, we hide the hand, the false hand, and then we ask the person where their real hand really is. And then we measure a very simple, numerical measure of their drift. And there is a questionnaire that we can use, which it's called it's a validated questionnaire, which tests this illusion. And there are about 11 questions there. What's in bold is the true questions eliciting the real illusion. And then there's a number of false questions, which are to trick people who are making things up, which is the false illusion, the false illusion. Questions such as, I felt the room temperature change, or it seemed like I was in two different places at the same time. That is not the rubber hand illusion. So they're mock questions. So in these critical 3 statements or questions which test this illusion, we found that in Parkinson's disease, with the synchronous stroking condition, which elicits this illusion, you couldn't tell people from Parkinson's disease, normal people from Parkinson's disease patients at all. And probably there's a ceiling effect. But when you move to the stimulus, which is asynchronous, which doesn't elicit the illusion as much, we found that people with Parkinson's, well, normal controls here, are able to reject the illusion, but people with Parkinson's disease can't. So there is, in this integration of temporal perception, of vision, so that is visual input about where your hand is, and sensory input, there is error, huge error, in the case of Parkinson's disease as a group of people. And then we find that in both conditions, in the asynchronous and the synchronous stroking condition, that people with Parkinson's disease are much worse. They make big errors about where their hand is after you elicit this illusion. We then thought, well, actually, you know what? It's very interesting. We do deep brain stimulation experiments. We can stimulate key nodes in the network in the basal ganglia. So why don't we, and we can do this at will in the sense that we can turn the stimulation on, turn the stimulation off. So we've got a beautiful controlled experiment in one patient. So we said, well, why don't we see whether we can alter these findings by turning stimulation on and off in a patient with Parkinson's disease. So we took some 20 or so patients, and then we also had our illusion data from normal controls as well. And then we were able to turn the stimulation on and off. And this kind of replicates most of our early work in just Parkinson's disease in the healthy controls. Here you find that going from the synchronous to the asynchronous stroking condition, that healthy controls really reject the illusion quite strongly. But people with Parkinson's disease, who are the grayed out boxes, they don't reject the illusion as strongly. That we've already found that. But if you turn the stimulation on, which is here, you can see that the gradient, this rejection of the illusion, starts to approach normal. So by interfering with neural networks, in this case, we were stimulating different nodes in the network. In 2 cases, the globus pallidus, and in 1 case, the subthalamic nucleus. We were able to more or less restore this abnormality of the illusion. And similarly, we were able to restore proprioceptive drift by stimulating the brain. So, but then there's a little bit of a caveat. So the degree to which proprioceptive drift is actually corrected depends on the severity of their pre-test assessment, your prior, if you like, how bad you really are in knowing where your hand is to begin with. And with normal people, it doesn't really matter how bad, how off they are to begin with. It doesn't really change their proprioceptive inaccuracy as you do the experiment. But in Parkinson's disease, it is dependent on your baseline inaccuracy. And it turns out that if you actually stimulate the brain, that interaction between your baseline error and the errors you make increases when the stimulation is turned on. So then the next interesting question is, okay, well, we're stimulating the brain, but we are very crude. We put electrodes in the brain. We know a lot about the theoretical wiring diagrams about the brain and where we might be altering networks. But what are we actually doing? Like, which networks are we really altering? And so we, my current PhD student Here's Fiona Permazel. At the moment, Fiona's at the Mayo. She's doing the next couple of years of her PhD there. Is using some of these more advanced methods of mapping networks in the brain and mapping exact stimulation sites. And a lot of the methods here are really in quite a recent paper. I think this was on the cover of Nature Neuroscience last year from Andreas Horn's group. In there are some of the great names in the area of the physiology of the basal ganglia, Marlon DeLong, who kind of worked out the wiring diagram. And there are many publications from this group. Andreas is now in Harvard. He was in Kiel, and these are many, many groups. This is a conglomeration of various centers, DBS centers in Berlin and even China. And this is another paper where these techniques are kind of described. So I've just put these up if anybody's interested in these techniques from the same group. Again, Andreas Horn is the main author. And here, the fundamental idea is that we are trying to find, in the case, most of this work was driven by understanding how motor improvement occurs after deep brain stimulation, what networks are involved. So we have a dependent variable, and in most of the early work in this area, the dependent variable was the change in the motor score, the improvement, if you like. But here we can use, when we're interested in studying something else, for example, multisensory integration, which is kind of what we're doing in this rubber hand illusion. We could have different dependent variables and apply the same methodology. So we can look at these, this illusion and drill down into a little bit. And here we say, if you look very carefully at these three key questions, the true questions, not the mock questions, what do they really tell us? And what are these kind of undescribed senses that we're talking about? Well, we can't name them really because we don't really fully understand. So we're just calling something where there's vision and touch being integrated. We just call it stroking in this case. It's a dependent variable tag for this particular measure. And the two of these questions kind of go to that. They speak to that. A question, I felt that the touch was caused by the paintbrush that I could see touching the rubber hand. Another question, it seemed like I was feeling the touch of the paintbrush where I saw the rubber hand being stroked. So it's an integration of sensation and vision. And somehow it's the resolution of the ambiguity between those two inputs, which is what generates this illusion. The brain failing to resolve it properly. And then there's another aspect to this, which is I feel, and you saw that young woman say, oh, that's weird. I feel just like it's my hand. And that's a sense of body ownership where the person has acquired a sense of ownership of the rubber hand. It feels like her hand. So that's a different sense. So we split this into two kind of dependent variables addressing slightly different ideas. And so we came up with 4 dependent variables. In this case, the UPDRS score is a score of the motor function. This has been extensively investigated with these techniques that I'm talking about. But then we then had ownership, stroking, and drift, which is something that we could, proprioceptive drift, is something that we could readily measure. And we had as the dependent variable the percentage improvement in each case. So we use a advanced imaging pipeline called LEAD DBS developed by Andreas Horn. There's a website for it. And in brief, what we do is we do a CT scan of the patient with the leads in their brain after the operation. And then we can co-register this CT scan with a preoperative MRI. There's a linear co-registration algorithm called Advanced Normalization Tools. I think it's part of SPM. We refine these co-registrations. After the operation, when these CT scans are done, there's some air in the head which is leaked into the hole that the surgeon made. It shifted the brain a little bit. That's called brain shift. We mask out the center part of the brain where there's not so much shift, and then we correct for that. We use Simon Oxford, one of the authors in that paper, developed a module in this lead DBS called Warp Drive, where we do some non-linear warping of the local field in around the brainstem. And then we reconstruct the DBS electrodes from the CT scan. And there's a couple of algorithms. In this case, we're using something called a Pacer algorithm. Then we've got very, very detailed and highly refined atlases of the brain, which have been developed by a combination of techniques: histology, electrophysiology, and network mapping. And these atlases exist, and these are segmented. In this case, mostly we're dealing with the subthalamic nucleus, where we've put these electrodes into the various parcellations or regions of the subthalamic nucleus, areas that connect with the limbic system, which are to do with emotion, areas that connect with the association cortex, which integrate cortical input from different parts of the brain, and of course the motor system. And this is a tiny little structure. It's about 240 millimeters cubed. It's the size of an almond, if you like, but it's got widespread connection all over the brain on both sides. And that's where our electrode is, our stimulating electrode. And then we visualize this in as groups. So we can localize these electrodes. This is the subthalamic nucleus. Here, this is an overlay of the Montreal template MRI. It's a 3 Tesla T1 MRI. This is where all our active electrodes are in red. So they're stimulating this. This is optimal stimulation. This is where, when we stimulate, I should say, explain a little bit, that when we put electrodes in, these are quadrupolar electrodes. We've got 4 terminals, and we can stimulate them in various arrangements and configurations. Most of the active terminal that's being stimulated in red here sits in this upper part of the substantia nigra, this almond-shaped structure here, and just above it, it's contacting the motor tracts that emanate from there. It's connections with the motor cortex. So that's where the electrodes are actually sitting in our patients. And this is the same thing in a kind of a point cloud demonstration, showing where all the electrodes are. And these electrodes have been chosen because they've given the optimal motor benefit for the patient. This is trial and error of programming of the device afterwards. And you can see most of them are contacting the motor region of the subthalamic nucleus. But there are some electrodes which are in the associative area, and very few in the limbic area, which has connections with centers to do with emotion. And then we can reconstruct a kind of a field, an electric field, a mesh arrangement here, and which is a volume of the tissue that's really stimulated or activated by our active electrode, and reconstruct that. So in red here, these are the so-called VTAs. This is an example of a volume of tissue of activation. And what Fiona has done is that she's done this for all our patients. It's a very, very complicated side, but I don't really want to go into any of these real details here, but it's the pattern I want you to see, is that she's got our dependent variables down here. And let's focus on our rubber hand one. For example, drift. And these are strengths of R values, or regression coefficients of the area of overlap of the VTA, what you saw in red, with the region of the subthalamic nucleus that we were studying. So it's a simple overlap. So that we've correlated with the change in the dependent variable, and we get a regression coefficient. And so there's a regression coefficient here. So we've got moderately strong associations between a dependent variable and a particular region. And this number here is the p-value, so the significance, statistical significance of that. What I really want to show you is that if you look in the case of drift, the motor area of the subthalamic nucleus and the association area are where most of the active electrodes are actually being stimulated. And it is those electrodes that are down in the limbic area, these connections which have to do with emotion, which have the highest correlations with the body ownership aspect of our illusion. And then this is the top panel here is the actual areas of the subthalamic nucleus. And then we look down a little bit below, but what about the tracts emanating from this, the fiber bundles, the connections to various areas of the cortex? And the motor tract, we can see, is strongly associated with the improvement in the drift, but also the associative tracts, the tracts that come out of the association STN. And in the case of ownership, interestingly, the tract, which is pooling inputs from a variety of association areas of the cortex. So here's a kind of if you like, a kind of a basis for trying to sort of understand how these things or where these things are being, these inputs are being integrated in the brain. Then there's some more advanced techniques that we can use using lead DBS. And I'm going to very quickly present this because this is a work in progress at the moment, which she's currently working through at the moment. We can take these fields, these volumes of tissue of activation that I just showed you. We can actually treat them as an object and warp them into the template, which is the Montreal Neurological template. So we put them all in a standard space. We take everything that's from the patient and map that back to some standard template. This is a T1 MRI scan. And these E fields, we can then map them into a grid. And then we can do exactly a very similar thing that she's already done with a simple overlap technique, where we can then do a regression analysis between the dependent variable change. In this case, they've shown, this is a picture from Andreas Horn's paper, percentage clinical improvement. And then we can develop from this map, if you like, again, R values, regression coefficients, what we call sweet spots, areas that when stimulated are highly correlated with the motor improvement. And there are areas where if you stimulate there, the opposite occurs. That's called a sour spot. So this is called a sweet spot explorer. The MRI, the magnitude of the electrical field, it's called an E field, is correlated with this clinical improvement. And we get these kind of sweet and sour spot maps. And then we can get another data set, which is connectivity with so a different atlas. We can use resting state MRI from 1,000 healthy participants and use that as an input. So we can correlate the fMRI data set with, again, our E fields, the electrical fields around the terminal. And we can sort of average it, an average based on 1,000 normal brains in this database, a kind of a functional connectivity fingerprint of where in the brain these areas are ultimately connected. Where in the cortex these areas are ultimately connected. And we can correlate those fingerprints with individual improvements in the dependent variable, and then again generate these regression coefficient maps, which are probability estimates of a connectivity profile for any particular dependent variable that we're interested in. For example, body ownership, where the work is of course, in deep brain stimulation is understanding motor improvement, because that's what that treatment is for. It's a therapy. So that's the second aspect of it, which is there are many other techniques, but these two are two that she's chosen, which is network mapping. And this is some of the preliminary data. This is a sweet spot analysis of our patients who entered into this study, which is the motor improvements called the UPDRS. This should be beta, actually, the Greek letter beta, it's B. But we've got some covariates, which are the age, the gender, the cognitive status of the patient and the site of the onset. And what's in red here is the sweet spot mapping, where based on our electrodes is the sweet spot for motor improvement in the subthalamic nucleus. And this sweet spot is pretty much where others have found the sweet spot to be, which is the dorsolateral subthalamic nucleus. We're happy that our patients are behaving pretty much the same as everybody else in a deep brain stimulation operation. And then we're looking at these dependent variables that we're interested in, proprioceptive drift in the rubber hand experiment. And you can see that the sweet spot here is not where the motor improvement occurs, but here, down here, in a deeper ventrally and more medially in the subthalamic nucleus, which is the association part of the subthalamic nucleus, which makes kind of a lot of sense. And ownership, the sweet spot here is in the limbic SDN, very low down. This is the area, the part of the SDN has that widespread connections with areas of the brain that deal with things like emotion. And this is some early data that she's generated on a data set called the PPMI 85, which is on 85 Parkinson patients, which is the connectome in Parkinson patients trying to map the areas of the brain in a data set that's relevant to Parkinson's disease. Yeah. So again, this is the motor improvement. This is drift. Again, this is the association cortex, which is largely a sour spot, if you like. Not so much a sour spot, but a negative correlation. But the frontal association cortex is heavily involved in the in this particular dependent variable, which is drift, and the prefrontal cortex in touch. Now, I haven't gone through all of the dependent variables because she's currently doing this. So what does this all mean for Parkinson's disease, and where does it really take us? Well, the first thing that I think it's important, and I've taken this picture from Andreas Horn's paper in Nature Neuroscience, where these kind of techniques were applied not just to Parkinson's disease, which is in green here, but several other conditions where the subthalamic nucleus has been stimulated. For example, Tourette syndrome, dystonia, and OCD. And he's done sweet and sour spot mapping from a number of centers and integrated all of this into a map of which part of the STN is being stimulated to achieve better outcomes in each of these diseases. And they're very different diseases: dystonia, Tourette syndrome, obsessive compulsive disorder. And yet it's this one central node in this network that is being stimulated here, and it's in different areas of this node that are being actually, stimulation is achieving the best results. And similarly with the connectome, different areas of the cortex, again, color-coded for each of these diseases. So same little almond structure, almond-sized structure, 4 different diseases, nothing like each other. and different areas of that node being stimulated and different cortical activations. So this is leading us to an idea which gets away from the pathology of disease as a unique kind of signature, and this is a coin that he termed, which is the dysfunctome. This is about where things go, where the symptoms are, where the disability is. And this gets us to another term, I think, which is a kind of a buzzword these days called personalized medicine, which is a bit suspicious because it sounds as though somebody's trying to sell you some deodorant. But it is really personalized medicine, because we should be now thinking not so much about treating diseases, but treating problems that the person might have. So, for example, if there is a problem with, shall we say, visual perception and its integration, maybe we would be targeting this area in a deep brain stimulation in the future based around that symptom and based around these kind of maps about which areas of the cortex are being activated and which areas in the node are being stimulated, rather than thinking about a disease. And the third, very important, which I'll finish now on this note, is that what we can also do now is try to relate this back to physiology, because we have now implantable devices. For example, we put these devices in patients now in the course of a deep brain stimulation operation, where we can actually record from the brain. These devices, this recording does have some kind of limitation. The sampling rate's only 250 hertz, but we can record not individual neuronal outbursts, but oscillations. For example, we've got here, and this is a spectral analysis, which I did intraoperatively, recording as we traverse the subthalamic nucleus with a recording microelectrode, that we generate these abnormal signals in the beta region here, which are a characteristic electrical signature of the motor, some of the motor dysfunction. And we can record these very same peaks in this Fourier analysis afterwards in the patient after they've gone home from the device that we've implanted. So we should be able to now correlate network activity in the free moving person in their own environment, which will lead us to test and investigate a lot of hypotheses and generate new hypotheses about how the brain works in making us the humans that we are. Thank you.
Thank you, Dominic. We just have time for a couple of questions. Grant?
Fascinating talk, Dominic. Thank you. So how much of that direct assessment of the sensory perception is done in kind of routine assessments of people with Parkinson's to understand their impact? And do you think that needs to be incorporated more in terms of clinical trials of disease modifiers? We heard from Michael earlier about the GLP agonists, for example, to measure those non-dopamine impacts.
Yeah, I think that's a very important question. So much of what is clinical drug trials is focused on the motor system. So much of the disability, of course, a lot of disability does come from motor dysfunction, but there are all these things. When we actually do deep brain stimulation operation, we do improve the quality of people's lives, but we know that a lot of the poor quality of their life that remains is actually about non-motor aspects of their disease. Not all of that is, shall we say, sensory. A lot of it is to do with mood and sleep and so many other aspects, like in the story that I told you about. But we don't measure that in drug trials. Those are not outcomes that are captured. There are questionnaires to capture non-motor symptoms, but they're pretty crude. What I was showing you there was a laboratory experiment, but there's no reason in this era of being able to do things online to collect neuropsychological test results from testing of this type that is delivered via a simple web browser, for example. So people don't really even people, not necessarily Parkinson patients, don't really even have to go to any kind of laboratory. They can log on at home and be able to do this. And even without the use of wearable devices, which is another big area of growth in this area of assessing outcomes in Parkinson's disease treatment.
Okay, we have a question online from Jeff Stewart, who says, thank you for your work. In the rubber hand experiment, was there a difference between the left and right hands in view that PD patients can have unilateral tremor?
Yes, actually, in the experiment, we actually tested, we did test the site of onset. We chose to do that for the proprioceptive drift and the rubber hand illusion. There is no difference between sides in the experiment conducted in normals.
And we'll just take one more and then we'll wrap it up.
Thanks, Dominic. Really interesting talk. I was just wondering if pain is one of those perceptions which might also be integrated in the basal ganglia, and whether you can use these techniques for chronic pain management, and if that's an issue in Parkinson's.
Pain is a big issue in Parkinson's. Much of, shall we say, clinical approach to things is colored by early descriptions. James Parkinson didn't examine any patients. He just observed them walking down the street. He was not really there to ask them about pain. But pain is often there at the onset of the disease. Pain can be part of the dopamine off phenomenon. It can be very severe. It can be disabling. Whether pain is is integrated into some of these networks that we're stimulating, I don't know. If you're asking a clinical question, is patients who suffer pain, can we improve them with a deep brain stimulation operation? The answer is, if the pain is part of their off phenomenon, where their motor fluctuations have led them to be in a motor state which is poor, and pain's part of that, then it's likely that if we reduce the number of offs, that we can reduce the amount of pain. The other question about modulation, brain modulation for pain is a very big area, and has been done extensively in the past. And yes, the answer is pain can be modulated with stimulating various areas of the brain. And we do use in some of these, there is some data that other parts of the network in the thalamus, for example, or in the periaqueductal gray region can be stimulated to alleviate pain.
Great. Thank you, Dominic. We'll wrap it up there. Everyone, please join us for the bake sale. That's just right outside of the room. Dominic will be around for a little while after the seminar if you want to have a chat with him. But please join me in thanking Dominic for a really interesting seminar.